just loading. Okay, we are live. So good afternoon, everyone. Thank you so much for attending our session today. Before we begin, I just want to acknowledge with a heavy heart what an important day in history today is. On this day in 2001, thousands of lives were tragically lost. So as everyone here listens to our shadowing session, we just want to take a moment to remember the mothers, fathers, children, siblings, and friends that are no longer here today. And we want to just honor their memory and hold them in our hearts as we begin today's session. So with that being said, we are honored to have Dr. Oruwari, a surgical oncologist, as our guest this afternoon. As always, at the end, please remember that the Google form will be posted in the comments section. And Dr. Oruwari, if you want to begin whenever you are ready.
Okay, thank you. Hello, everyone. Thanks for having me. Like she said, I am Dr. Jovita Oruwari. I'm a breast cancer surgeon. I did all my training in New Jersey and then at Brown University in Providence. And I currently practice in St. Louis, Missouri. And I'm very active on Instagram. I think that's where you all found me. So today I'm going to talk about breast surgery or doing breast surgery, and I'm going to kind of talk about it from my perspective. And I'm going to go over a couple of cases, which I hope will be helpful to give you a little bit of that clinical aspect that you're not able to get right now because of Corona. So can everybody hear me so far? Okay.
Yes, we can hear you. Thank you.
Okay, perfect. All right. So, so you want to be a breast surgeon. What does it take to be a breast surgeon? Well, you need to do 4 years of college, which you all know. And in college, you need to take the MCATs. I know some programs are starting to waive the MCATs, so that's something to look into if you're not a good test taker, just to see if you can try to get to med school without taking the MCATs. 4 years of medical school, and then 5 years of general surgery residency. Following that, there will be 1 or 2 years of breast surgery fellowship. Most of the fellowships right now are 1 year. I believe it's only one program that's 2 years. So for the most part, everybody does a year of breast surgery fellowship, and that's just intensive training doing breast surgery. Once you are done, what comes after that is essentially being employed at a teaching hospital or being employed at a community hospital. Or if you do not want to be employed, you can go into private practice either by yourself or with or in partnership with other surgeons. So there are lots of good options when you are done. And there's pros and cons to each, and if that's something somebody's interested in, we can talk about it a little bit more at the end of this. Okay. So what's the scope of my practice? What do I do? Say I'm a breast surgeon. What does a breast surgeon do? I see all ranges of breast problems. I see breast pain. I see people with breast lumps. I see people with cysts in their breast, people with nipple discharges, people with axillary masses. So there's the masses under the armpit, people who have breast infections, people who have skin lesions of the breast. Some women come in because they had a mammogram that was abnormal. Some women come in because they have a family history of breast cancer. So women come in just because they want to be screened because they feel that they are high risk. And these are the women who have the high risk of breast cancer, like family history, et cetera. So women come in because they want to get genetic testing to make sure that they are not at risk for breast cancer. I also see men. Men come in with different breast lumps. Luckily, a majority of them are benign, but some men do have breast cancer. It's about 1 in 100 men will have breast cancer. So it does happen. It's just something definitely to be aware of. So that is the scope of my practice, what I see. It sounds like a very limited area of the breast, very limited area of the body, but there's really a lot within that limited area that we do. What is the function of the breast? Well, the breast, for the most part, has the function of making milk so that you can breastfeed. That is its number one basic function. The other is that it's a sexual organ. So it does have some nerve endings. It's become kind of a sign of beauty in most societies, but its main function is that of breastfeeding. The anatomy of the breast, essentially, the breast looks kind of like this. I don't know if you can see my little pointer here. I'm gonna have a little red dot pointing to this. So this is kind of the outline of the breast. And here is the nipple. Within the nipple, we have multiple milk ducts that end up in the nipple. These milk ducts kind of branch out like trees into the breast. As they branch out, they end in little lobules or sacs. This is where the milk is actually stored. Then the milk is released from those lobules and go out through the milk ducts and out the nipple. In between the milk ducts and the milk sac, we have lots of fatty tissue and lots of lymphatic tissue. Behind the breast, we have the rib cage and muscles. And then of course, behind it is the heart and the lungs. But the breast sits on the chest muscle. It does not have any muscle within it. It just has milk ducts, milk glands, fatty tissue, nerves, and lymphatics. And that's it. So now we're going to go into the first case. I'm going to first present to you a 15-year-old girl who comes in, because I do see a wide range of women. I see girls from 9 years old to women who are in their late 90s, hundreds. So this is a 15-year-old who comes in with a lump in her right breast. Okay. So what do you guys want to know about her? She comes in to see you. Is there anything that you want to know right now? Anybody? No? Okay. I'm going to continue then. So these are the questions that I would want you to ask this particular patient, this 15-year-old. I would like you to ask her, how long has this been there? When did you first notice this? Where is this lump located? Has it grown in size? Is it painful? What makes it feel better? What makes it feel worse? So for this particular patient, her answers are, she noticed it about 6 months ago. She noticed it during her menstrual cycle. It's in the lower inner aspect of her right breast. She notes that it has gotten slightly bigger over the past few weeks, and it tends to hurt around her period, but otherwise nothing makes it feel better, nothing makes it feel worse. So I would have some additional relevant questions for this patient because I'm a breast cancer surgeon. So I would want some obstetric history. I would want to know how old she was when she first started her menstrual cycles. If she's had any pregnancies. I know she's only 15, but we have to ask that to everyone because we have different patient population that we see. So she was 11 when she first started her periods, and her periods have been pretty regular. She's never had any pregnancies. Her maternal grandmother had breast cancer at 65, and she has no prior breast surgery history. So these are all relevant questions related to the breast that you need to ask. So based on all of these questions, what will be the next step? What do we do next? The next thing to do, does anybody want to take a stab at it? No? Okay, so the next thing would be to do a physical exam. Physical exams are very important to every practice. No matter if you are an eye doctor, an orthopedic surgeon, other type of surgeons, internists, gynecologists, pediatrician, physical exam is just very basic. It's something that they go into full extent when you're in medical school and beyond, because it's that important. You have to learn how to examine the human body. So for this particular young lady, on her exam, she's healthy, she looks well nourished, she's well developed, she's in no distress. Um, she has a 2.5 centimeter well circumscribed mass at 4 o'clock area of her right breast. Whenever we talk about locations on the breast, we kind of want to look at the breast as if it were a clock. So the 4 o'clock position of the right breast will correspond to the lower inner quadrant of that right breast. Other than that lump, she had nothing else that was palpable. So based on this, we can't make a diagnosis just yet. We need to figure out still what is going on. I've examined her. I know she has a lump. I know that, I have things in the back of my head as far as what this lump may represent, but we don't want to guess. So I want to get some x-rays of her breast. So we'll do a breast imaging. The breast imaging that we would want to use in a 15-year-old girl is a breast ultrasound. The ultrasound uses basically ultrasound rays to look at the breast, where it differentiates between fatty tissue in the breast and lumps. And in this girl in particular, she's got this lump here, which looks like it's nicely demarcated. So it's what we call well circumscribed. Another reason we would not want to jump into a diagnosis without getting the imaging is because there are several types of lumps that we see in the breast. There are what we call solid lumps and what we call cystic lumps. Cystic lumps are lumps that are just made up of fluid. It's just all water. A lot of women develop cysts in their breast because of the normal menstrual cycle that they go through. So if you put a needle in a cyst, you're going to be able to pull fluid out. And it almost like popping a balloon, it collapses the lump and makes the lump go away. But if you put a needle in a lump and you don't get any fluid out, that means that it's a solid lump, it's all tissue. So this is what we call a solid lump because it's all tissue in here. So this is what we see in that young lady. As opposed to this is what we call a cyst. Again, it's well circumscribed. The inside of it is completely black. Black usually denotes fluid in an ultrasound. So this is an ultrasound imaging of a cyst. So for this, I would know it's a cyst. Cysts are benign, they're not cancerous. We don't have to do anything else with it. It can be left alone. But cysts can sometimes be painful, which if it is, would oftentimes put a needle in and pull out the fluid so that the lump would go away and the pain would get better. But this young lady, I'm just going to go back to the other slide, has this. So that's not completely black. So it's not a cyst, it's a solid lump. So because this is a solid lump, we have to start to worry about cancers because cancers tend to be solid lumps. And because I feel it and I see this, I can't tell just by looking at this or by feeling it whether it's a cancer or not. So the next step would be what? So we could either make a decision because she's 15 and breast cancer is pretty rare in 15-year-olds. So we can make a decision to just have her come back in 6 months and re-examine her and get another set of ultrasounds to see if it's grown, and that would be okay. Nobody would fault you for doing that just because she's 15 and we don't suspect that it's a cancer. So that's one option. The second option is to do what we call a core needle biopsy. And this is just a way of taking a piece of that tissue so we can look at those cells under the microscope to test it. So this here is on the left side is a core needle device. So it's, as you can see, the diameter is bigger than your typical needle that you would draw blood with or get an IV with. The diameter is big enough that we can put it through, in this other picture here, through the skin of the breast, pass it into where that lump is, and withdraw a piece of that lump. So that piece of the lump that we withdraw, we send it off to pathology, and they will look at the cells under the microscope, and then they'll be able to tell us what the lump is. In this young lady, that lump is what we call a fibroadenoma. So fibroadenomas are very common in young women. We usually see it from age 11 to 30s. They're typically firm, they're rubbery, they're smooth, and they move. When you touch it, they kind of move about the breast. It's usually painless. When I see girls with this, there can be multiple of them. There can be lots of them, and they can be on either side of on either breast, right? Some people have on both breasts at the same time. We don't know why some girls or some women get these. We know that it's less common the older you get. So we think a lot of it has to do with the hormonal changes that we go through as we start to go through puberty. We also know that they can grow over time. So if left alone, they can grow over time. When it starts to grow, a lot of times we'll end up doing surgery to remove it, and that's not a huge deal. Overall, these lumps are usually benign, which means that they are non-cancerous and they don't lead to cancers. So that is the first case.
Sorry to interrupt quickly.
Sure.
Would you mind please pressing the play button on the top of your screen just so we're able to see it fully?
Oh, I'm sorry. Did you not see it? Oh, good. I'm so
We
sorry.
could see the screens. It just expanded a little. Perfect. Thank you so much.
Okay, you are welcome.
And I will be sending questions into the chat if you want to look there.
Okay. I can see it. Okay. Okay, I'm gonna continue. Does anybody have questions about that benign that I just presented? Okay, so the second case that I'm gonna talk about is a 45-year-old woman who came in with a new lump also in her right breast. So she's 45, so my scope of thinking is a little different. With a 15-year-old, I'm thinking it's not cancer, it's gonna be benign, or it's gonna be a cyst, so fluid-filled lump. With a 45-year-old woman, I'm more worried about breast cancer. So these are the questions that I would want to ask this lady. I would want to know, when did you notice this lump? Has this lump changed in size recently? Is it painful? Then I want to know, when did you start to menstruate? When was your first pregnancy, or have you had any pregnancies, or when was the first baby born? What's your family history like, and have you had previous surgeries? Now, all of these questions are pertinent to breast cancer, so that's why it's important to ask. So knowing when her period started is important, because it helps me to, if this is not a cancer, it helps me to calculate what her breast cancer risk may be, because we know that women who started menstruating at a younger age and stop menstruating at an older age have a higher risk of breast cancer. We also know that women who had their first babies before the age of 30 have less of a chance of developing breast cancer. Family history, of course, impacts breast cancer. And then prior breast surgery history is also important, because I want to know what the surgery was for. Was it for cancer? Was it for something benign, but possibly carries a high risk of breast cancer? So it's important to know all this. So this particular woman says she noticed this lump last week in the shower. It has not changed in size. There is no pain at all. She started her first period when she was 13. She has had 3 pregnancies, and she was 25 when she had her first baby, and she did breastfeed. Her mom had breast cancer when she was 43, and she also has a sister who had breast cancer at 39. So that's a pretty significant family history to me. Otherwise, she has had no previous breast surgeries. So other questions that I might want to ask someone who comes in with a history like this is, I would want to know, is she Ashkenazi Jewish? Because we know that women of this Jewish heritage have a high risk of genetic mutations that lead to breast cancer. So knowing that will help us direct what the next stage of screening would be. Women who have had previous radiation exposure to their breast also have a high risk of breast cancer. So radiation for thyroid cancer, radiation for lymphoma, usually radiation exposure in younger years, like teenage years, later on in life can translate to higher risk of breast cancer. Women who do not breastfeed have a higher risk of breast cancer. We don't know why this is, but that's being studied. And then lifestyle factors can also influence breast cancer. So I'd want to know if a woman smokes, if she drinks, if she's overweight, and what her diet is like, because high fat diet increases breast cancer risk, small risk, uh, small increase in risk with women who are more sedentary. Of course, smoking increases risk for lung cancer. Okay. So the next thing I would want to do is to examine this woman. And this particular woman, again, just typical appearing 45-year-old mom. She's healthy, she's well nourished, she's well developed. She's anxious, but she's not in any kind of distress. Her breast size are about 34C. I put this here just to say that we're always thinking about breast size and breast surgery, because that impacts on the surgery that I would do, and also impacts cosmetically on if we're taking out breast tissue and what's left, etc. She has 1 centimeter firm mass at 7 o'clock position of her right breast. It's not tender. She has no abnormal lymph nodes palpable. So what is going to be the next step for this lady? Any takers for her? What should we do next? We've examined her, we feel what we feel. What's the next step? So kind of like the other lady, actually, before I talk about that, just want to stress that a breast exam is very important for anyone who comes in with any type of breast concerns. And the way we do breast exams in breast surgery is we want to first evaluate the breast, just looking at the breast. We're looking, make sure the breast is symmetric, make sure the nipples look normal, make sure the skin of the breast look normal. There's nothing, no rashes or bumps that we see on the skin. And then we want to feel, we are feeling for lumps in the breast. I usually like to divide the breast into 4 quadrants because that kind of helps me make sure I don't miss anything. And I start from the outside and go towards the nipple. And I do that completely for both sides. And then it's important to check under the armpit on both sides, because you're feeling for lymph nodes under the armpit, on the axillary lymph nodes, we call them. And you also want to feel for lymph nodes above the clavicle. So those are the supraclavicular lymph nodes. So those are the places that breast cancer will tend to spread to when it leaves the breast. So it's important to check those areas. So she's had her exam. So the next step is breast imaging. The mainstay of imaging for breast cancer doctors is mammography. Mammography is very important. We recommend every woman over the age of 40 get a screening mammogram once a year. And what the mammogram does is really just takes pictures of the breast. It's going to look at the breast in 2 views. So it's going to look at it from top to bottom, and it's going to look at it from side to side. It's going to do each breast individually. And we're looking for things like this mass here that we see. My pointer here. So right there, where the arrow is pointing at a lump in this breast, so that's something that's abnormal, because when you look at the other breast, there's nothing abnormal. This is just all the glands that make up the breast tissue is what you're seeing here. So On the right here, it's a normal breast. On the left here, that lump there is abnormal. And this is another mammogram that shows uh, pretty much similar. On the left here is normal. On the right here, there's this lump right in here, which is circled for you in red, is abnormal. So when we see something like this and we want to follow it up with more imaging, we know that there's something there. We know it's abnormal, but again, we want to make sure that it's not a cyst. Remember that first case in the beginning, cysts are those liquid filled lumps. So what we're gonna do is get an ultrasound because that's what tells us the difference between what's a cyst and what's solid. So I have two ultrasounds here of lumps that are solid. So unlike that first picture I showed you of the fibroadenoma earlier on, this is kind of an irregular mass. It's not well circumscribed like that first one is. This is kind of irregular. So these lumps are abnormal solid lumps. So this is something that I would recommend that we get a biopsy of to rule out cancer because, of course, I cannot um, tell you just by looking at it that it's a cancer. I mean, with expertise and knowledge and whatnot, I can say yes, it's a cancer, but you really shouldn't say that without the proof of pathology. So we've done the mammogram, we've done the ultrasound. In women under 60, I usually want to do an additional breast imaging, which is the breast MRI. MRI just uses a gadolinium, um, I'm blanking, a gadolinium injection to view the breast in a different way. So that this left MRI is a little busy, but the one on the right is just kind of a typical MRI that you would see, where on the right side, this is just a normal breast. Behind it, when you kind of look behind it, here is just the heart and the lungs is what you're looking at. So the women are usually laying face down for this particular image. So you kind of see the breast hanging down. That's why you kind of see it pointing down like that. Um, so in this MRI on the right side, if you see the little arrow there on the left is pointing at that little dot, which is an abnormal lump. So the MRIs are really good for breast cancer because it helps us pick up things that a lot of times you don't pick up on mammogram or even an ultrasound. So just an additional way for us to evaluate the breast and look for things that we may not be able to feel or see on the other imaging. So once we see what we see, we can now proceed with a biopsy to be able to tell now what this is that we're looking at. So we can do a biopsy either with the ultrasound on the left here, or we can do it with the mammogram. So just different ways of doing an ultrasound. I'm sorry, different ways of doing a biopsy. With the one on the left, the ultrasound biopsy, just basically we place an ultrasound probe on the breast. We view it on the ultrasound machine. We find the lump. We numb the skin, and we pass that big core needle biopsy device in through the skin into the lump and take a piece of it. The woman is awake during this procedure. We just numb the area that we're doing a biopsy for. With a mammogram biopsy, we usually do this because sometimes we can only see a lump on the mammogram. We cannot feel it and we cannot see it on the ultrasound. So if we only see it on the mammogram, we'll do this on the right, which we call a stereotactic biopsy. It's just a big, scary looking machine where the woman lies face down in it and we squeeze the breast the usual way we would for a mammogram. And you see these grids here, kind of measures how deep the area is that we're seeing on the mammogram. And then the computer kind of calculates and guides us to where the needle needs to go in. We numb the skin in that area and we pass the big needle through the skin into the area and take samples of the tissue that we need. So that's how we're able to do a mammogram biopsy. And then once we do that, the next thing or the next step is that that tissue goes to the pathologist. And the pathologist then tests the tissue that we send them under the microscope. And this is where we get the diagnosis. So my physical exam is guesswork. The x-rays are guesswork. The only way to diagnose a breast cancer is what we see under the microscope because we want to see those cells. So the pathologist will look at the slide that we send, the piece of tissue that we send them. They'll make slides. And this here is just a typical slide image of a breast cancer. So it's important for you all to know that breast cancer cells develop either in the milk ducts in the breast, so we'll call them ductal breast cancers, or they can also develop in the lining of the milk lobule or the milk sac, which we call lobular cancers. And then the breast cancers can either be contained within that duct or lobule, so we call those in situ cancers. Those are cancers we consider early stage cancers. Or once the cancer breaks out of the milk duct or the milk lobule, then we call it invasive ductal or invasive lobular cancer. And those are cancers that have the potential to travel. So now we know that they have a breast cancer. So the next step is to talk about doing surgery because we want to remove that tumor. We don't want to leave it in there. So the surgery options are either to do a lumpectomy, which is the top left picture here. A lumpectomy essentially means that we're going to make a small cut in the skin of the breast. We're going to go in and take that lump out. Not only the lump, but a little bit of extra tissue surrounding it because we want to be able to get all the cancer cells out, and we stitch it all up from the inside. So with a lumpectomy, the breast shape and size should not change. It should look the same still as the other side. All we're doing is taking out the cancer. Whenever we do a lumpectomy, we usually follow it up with radiation. So lumpectomy always goes with radiation because that decreases the risk of the cancer coming back. If we do not do a lumpectomy, the alternative is to do a mastectomy, meaning that we're removing the whole breast. So that is the top right picture. So typical mastectomy, the breast is removed, everything is flat. There's just a straight line that goes across the chest. But there's no breast tissue left on that side. And then there is breast reconstruction. I'm sorry, let me just finish up with the other types of mastectomy. So on the bottom left is what we call a skin sparing mastectomy. So all this means is that we're taking the nipple and the areola only. And then through that circle, we go in and remove all of the breast tissue. And then usually we'll put something behind it, like implant or something to reconstruct. So all we've taken out is the nipple, the areola, and the breast tissue on the inside. So that's a skin sparing mastectomy because we're leaving a whole lot of the person's natural skin. Now, then there's a nipple sparing mastectomy, which means that we are going to leave the nipple alone. We're not taking the nipple. We're not going to take any skin. We're just going to make a cut. A lot of times we make the cut underneath the breast. And through that, we'll go in and take all of the breast tissue and then put in either an implant or whatever to reconstruct. So that's reconstruction. And then breast cancer surgeries are also usually accompanied by axillary lymph node surgery because breast cancers, especially invasive breast cancers, can travel to the lymph nodes. So we always want to check the lymph nodes to make sure there's no cancer in it. So that's all part of the surgery. So this slide just really shows a typical mastectomy. This woman had a bilateral mastectomy, either because she had cancer on both breasts or because she had cancer on one breast and chose to have both removed, which a lot of women end up doing. And some people do it because they have the genetic mutation for breast cancer and they don't want to take the chance. So again, everything is flat and there's a straight line going across on both sides. When it heals up really nicely. This is reconstruction using breast implants. So some women choose to have the breast reconstructed or rebuilt. They just don't want the whole flat look. So these are breast implants on the left. Breast implants could be either silicone or saline. And we usually try to do the surgery at the same time that I remove the breast tissue. The plastic surgeon will come in and put the implants in. The implants go into where the tissue was removed, and it will look kind of typically something like this on the right. And then these are just other options for reconstruction where instead of putting in implants, some women choose to use their own tissue. So we would either take tissue from the belly with muscle or tissue and muscle from the back and kind of swing it up to where the breast is gone to kind of recreate the breast. So some people prefer this because it serves several purposes. First, we're reconstructing. Second, they don't have a foreign material that like the implant, because some women don't want the implant. And thirdly, for women who have like an extra pooch in the belly area, this takes that out. It's kind of like having a tummy tuck and breast augmentation at the same time. So again, this is something the plastic surgeons would do. This is not what a breast surgeon does, but we're all part of the same team, so we're in the same room at the same time doing the procedures together. Okay, so I just want to kind of finish with talking about the staging for breast cancer. The importance of what I do is that we want to encourage women to come in for breast evaluation earlier rather than later. We want to make sure women are getting screened when they're supposed to. Women are coming in because they felt something abnormal, because the earlier you come in, the higher the rate of survival. So as you can see here, women with early stage or stage 0 breast cancer have about 100% survival rate. And these are breast cancers that are contained within the duct or within the lobule, as opposed to women who have stage 4 breast cancer, which is a cancer that has spread all over, who have about 20% or less survival. So it's very important to be screened and come in early to be managed. So I am going to end there and see if you have any questions for me. Let's see, I think there were some questions on the, oh, I'm sorry, let me pull up the chart. Okay. Oh. All right, I'm gonna look through the questions. I'm sorry. What are the risks when getting implants? Is it true that silicone implants are not good for the body and saline are preferred? That's a good question. So saline and silicone are equally safe. The problem with the silicones was the old silicone. The old silicone had the old silicone was not safe, but nobody's doing that anymore. So today's silicone is safer than it used to be. The concern with the implants is the lining around the implants. That's where we noticed that there was a problem, and I believe that was back in 2019 or so. There was a problem. So all of those implants were recalled, and that company is no longer making those particular implants. So right now, the implants that are around, as far as we know, are safe. And they say implants usually should be in for about 10 years. And, you know, some women leave them in longer than that. But yeah, otherwise they're safe. But, you know, we're evaluating these patients pretty frequently after their breast cancer surgery. So we're able to determine if there's anything amiss in the follow-up. At what age would we get mammograms done if there is a family history? That is another good question. So for women who have a family history, I usually recommend that they start their mammograms either at age 40 or 10 years younger than their youngest relative. So if your mother was diagnosed when she was 44, you should start getting mammograms at 34. If mom was diagnosed at 54, then you start at 40 like everyone else. So it's 40 or 10 years younger if your loved ones were younger when they were diagnosed. Okay, so let's see. I'm trying to get to the questions at the top, and for some reason I'm not able to scroll to the top.
If you hold your mouse up to the top of the screen, a drop-down menu should come up where you're able to click on the chat.
Oh, okay, I think I got it. All right, there we go. How would you approach change if, how would you approach change if the patient was unable to provide a family history? You guys have some good questions. Okay, so I've had this happen actually quite a few times. So we have patients that for some reason were either adopted, so they have no clue what their family history is, or they're estranged from their families, or mom passed away at a young age, so they just don't know. So it's still 40 as far as getting the mammograms is when they should start. But if someone came in with an abnormality, they would still need to be evaluated because they have an abnormality. So they would need the mammogram, the ultrasound. If there's something concerning, would need to do a biopsy. But as far as the age to start screening, it would be 40 unless we knew other history. Um, so let's see what age. Got that answered. How do you see the specialty changing in the next 10 years? That is a great question. So we foresee, because I have seen it in my time in practice, we foresee that there will be less and less actual surgeries done, because I kind of started training when they stopped doing what we call radical mastectomies, which I didn't talk about it, but a radical mastectomy not only removes the breast, but it also removes the muscles underneath the breast. Typical mastectomy today, we're not taking those muscles, and that's why everything is kind of nice and smooth. But if you see a woman from like 30, 40, 50 years ago who had a mastectomy, the whole chest is kind of concave because they've taken so much out, and it's just really horrible surgery that they used to do back then. So we're doing less and less surgery. Um, we're doing more lumpectomies over mastectomies. We're also doing less axillary surgery where we're not taking all the lymph nodes under the arm, we're taking one or two to test them. So a lot of the morbidity and complications that comes with this surgery are lessened or much less than they used to be. We're looking at doing cryosurgery for breast cancer. So some centers are doing this right now on study or trial basis, but for women with smaller breast cancers, they'll insert a probe into the cancer and basically freeze it. And what we found is that after a few rounds of the freezing, when you remove the whatever is remaining of the frozen ball, is just all dead cells. There are no live cancer cells. So this conceivably may be the way breast cancer is going to change in the next 10 years, and that we'll freeze the cancer and not have a need to do surgery to remove anything. There's also been a lot of change in radiation and chemo, which I didn't go over too much, chemotherapy, radiation, because that's not my specialty, but I work in collaboration with those physicians. We have lots of new chemotherapy medicines that are more targeted. A lot of medicines today are based on genetics. So we're giving you medicines that are custom tailored to you as opposed to what everybody else would get. It would be something that that reacts well with your genetics. Radiation is the same. Radiation is getting less and less and more pinpointed. Okay, so I hope I answered that. The other question was, why do women who get pregnant before 30 have a lower risk of developing breast cancer? That is something that we don't know about and don't know quite why. We've been looking to study this, and it's been studied for years and years, but nobody really knows why. It may have to do with something protective in the estrogens during pregnancy that protects a woman against breast cancer. We don't know, but it is the case. It doesn't mean that women who get pregnant after 30 will all develop breast cancer. No, it's just a great percentage of breast cancers we see in women who got pregnant after the age of 30. What does a typical workday look like for me? Typical work day really depends on what I'm doing that day. So I'm a surgeon. So surgeons, for the most part, we divide our time and our days between being in surgery and being in the office. So I don't like to do half office day, half surgery day, because that's just gets a little crazy. So I like to spend a full day in the office or a full day in the in surgery. So right now I have 2.5 days in office and 2.5 days in surgery. My office days basically would start around, and everybody is different when their day starts. My office day would typically start around 8:30, 9 o'clock, where I would see patients, depending on how many patients I have for the day. It's like every 15 minutes is a patient. So it could be 20 patients or more or less. And I'll go till 5 or 6 o'clock. And the patients come in with a range of complaints, like you saw in the beginning of the presentations, all different things. I never know walking into a patient's room what it's going to be. I just know it's related to the breast. So it could be a breast cancer, it could be breast pain, it could be nipple discharge. Um, and then on my surgery days, I would typically start a little earlier, usually 7:30 or so, 7:30, depending on the day. And depending on how many surgeries I have, which I can't predict because it depends on what I see in the office and what we schedule. So it could be a full day surgery where I'm operating from 7 in the morning till 5. And we just basically line them up and do one after the other. Or it could be a short day where there's maybe one or two surgeries scheduled, so I'm done earlier those days. Um, what about this field do you enjoy the most? Um, I really enjoy my interaction with the women that I see. I think I posted something about this earlier today. I enjoy my interaction with my patients. A lot of my patients, of course, are women. They're moms like me or wives like I am, with families and jobs, and women who just need to get through this cancer thing to get back to their life. So I enjoy being part of their process of getting well, of getting better. I enjoy my interactions with them, my talking to them in their office, my kind of going through the journey with them. I enjoy the teaching aspect of it, teaching them about their disease and what to expect and how to get better from it. I enjoy doing surgery. I enjoy being in the operating room. But what I really like about this is that it's one of the only specialties that kind of um, gives you continuity of care that you don't get in general surgery, which I'm general surgery trained, but a general surgeon who does an appendix, you take out an appendix or a gallbladder and you say bye-bye to the patient and they're gone. You don't see them ever again. But with a breast cancer patient, you continue to see them for years after the diagnosis. So you really form friendships and family with these women. So I like that continuity in addition to doing the surgery part. Okay. What are the differences in examining a female and a male patient? There's really no difference. You're going to approach your exam the same exact way. And as a breast cancer surgeon, my focus is always on ruling out cancers, whether it's a man or a woman. And, there's some women that are smaller breasted. So it's almost like examining a man. So it's no difference. You're feeling for the breast tissue, you're feeling for lymph nodes the same way. And as far as the imaging, yes, we do the same imaging. We do the mammograms, which some people jokingly call a manogram when we do it in a man. And we do ultrasounds also in men to evaluate the breast same way we would in a woman. So the size of the breast does not matter in getting those imaging tests. Where did I go to undergrad and med school? I am a Jersey girl, so I went to Rutgers undergrad and went to medical school at Rutgers, Newark, New Jersey. I did all of my general surgery training also at University Hospital in Newark, and then went to Brown University to do my fellowship in breast cancer. Do people usually get referred to you by another doctor, or do they come directly to you? I see both. I see women come in to see me because they've been referred by a friend or family member, or they've heard of me. And then some women come directly from their gynecologist or their internist because during the course of their normal exam, the doctors felt something or something, or the patient called them with a concern. So that's when I would see them. Um, let's see, what was that question? What are your thoughts on electrical devices causing or contributing to breast cancer, such as having your phone in your pocket or the microwave? You know, those are all things that have not been proven right now. So I really can't comment on it until there is data to that effect. So right now, I'm gonna have to say I don't know because we don't have enough information. How often do you deal with male patients? Actually, not often. I want to say about 2 male breast cancers a year that I've seen. And a lot of the men that I see come in because they have what we call gynecomastia. So I'll see like teenage boys would come in. There's sometimes in some boys an imbalance of hormones during puberty that causes an overproduction of estrogen, which are the female hormones. So these boys will tend to grow a whole lot of breast tissue. So that we call that gynecomastia. So because of that, they're very self-conscious. So they get teased at school. So they'll come see me for that. And we usually work with the endocrinologist to figure out if it's a hormone imbalance and what to do about that. Usually will not do surgery in a man or in a guy at that age because a lot of those hormone changes will reverse and those things reverse and the breast shrinks and gets back to normal. How many hours is my average work week? Depends on the work week, I think. And a lot of times you make your own hours. You can work as little as much as you want to work. So I'm usually 8 to 5 on office days and probably about the same on non-office days. So what does that make it? 5 days a week? Like 40 hours or so? 9 times 5, yeah. Yeah, about 40 or more hours. I don't know. I really honestly don't keep track. Some days I'm there till 7, 8 o'clock at night. Even on surgery days, there's some surgery days where I'm there later than I anticipate, and I just kind of take care of patients as they come in. But for the most part, I try to be done by 5 or 6. Um, if you could pick another specialty, what would it be and why? Oh, wait, I missed something up there. How did you prepare for applying to medical school? Um, I think that you guys are probably more prepared than I was when I applied for medical school because we didn't have all of this internet stuff and, you know, people advising you and talking to you and whatnot. I just knew I wanted to be a doctor and I knew I had to take the MCAT. So I took the MCAT. I don't believe I did any type of shadowing, but those things are all important today. So it's important to try to volunteer at a hospital, try to find doctors that you can shadow in their offices, try to spend some time in the operating room, try to do research. If you're at a school where there's research, try to do some kind of research. Those things all look good on your applications because the average student applying today to medical school is really good because you guys are all amazing. So it's so hard to pick who is more amazing than the last person. So all the extra things that you do helps to get your application to that top of the stack where we can look at it more favorably. So those are the things that I would advise. Um, let's see, if I would pick another specialty, what would it be? You know, I went into med school wanting to be a gynecologist, which I did not like at all. And I rotated through it and I loved surgery. If I was not doing breast surgery, I think I would be a urologist because that is a specialty of surgery that I really enjoyed a lot. I enjoy the surgery. I enjoy um, the attendants that I worked with and the patient population, and that's probably something that I'll think about. But um, okay, what's the next? Could you elaborate on how asymmetry can lead to more likelihood of breast cancer? How do you know normal versus not? Um, so asymmetry does not necessarily lead to breast cancer. Asymmetry is important because you want to know a woman's baseline. I think we are all asymmetric to some extent, but significant asymmetry is when it's something that happens suddenly. You've always been symmetric, but over the past couple months, you notice that one was bigger than the other, and it's significantly bigger, but a cup size bigger or more. So that is significant. And the reason that that's a concern is because some lumps can get so big that it makes one side bigger than the other. So that's why we'd have to evaluate with exams, imaging, and biopsy if necessary to make sure it's not a breast cancer. And everyone or every woman should know what is normal for them. And this is something that most people start to learn as they go through puberty, what's normal for them, so that as soon as something becomes not normal for them, that's something that they need to come in to be evaluated for. And yes, the surgeries I do for the most part are outpatient. We usually would keep patients overnight after a mastectomy. So we'll do the surgery, say today, and we'll send them home the next morning, and they do really well. And what did I major or minor in? I majored in zoology and I minored in chemistry and math. Do you do genetic testing or do you refer them to someone else? I do most of my genetic testing just because it's, you know, I'm a specialist. It's something that I've been trained to do. It's a couple of insurances that want you to send the patient to a genetic counselor. So those will send to the genetic counselor. But I can, so as far as breast cancer, I can counsel the patients. I can do the testing and all of that because it's part of what we're trained to do. Work-life balance. Ooh. Very, very important. Very important to me. Just something that's very important for you guys to kind of start working on right now also. Um, Medicine can be all consuming. So it's important to make time for yourself, make time to exercise, make time to eat healthy, make time for your friends, make time for your family. Because the majority of your time will be spent studying, but you don't want to miss out on those other connections that make you human, that make you you. And being connected to all of that other stuff also makes you a better doctor because you don't want to be that doctor that comes in and the total complete nerd and cannot relate to their patients. You want to be able to relate to your patients. You want to be able to talk about anything that your patients talk about. If they talk about gardening, you want to be able to chime in and say something. They talk about that football game over the weekend. You want to be able to talk about it with them. Those are the things that make you relatable to your patients and make you more likable to your patients. Do I feel grossed out or nauseous the first time I watched surgery? I did not. I felt pretty much at home the first time I was in surgery. Like I said, I loved it. I felt that that's where I belonged. And I do know some surgeons that have had, you know, moments where they were nauseous in the beginning, but they've gotten over it and they're fine now. So if you happen to go into surgery the first time and you're nauseous or woozy, don't rule surgery out. It doesn't mean that you can never be a surgeon. Sometimes the first time is quite a shock.
Thank
Okay.
you so much for taking the time to speak with us today.
You're wel-
It was an honor and privilege to have you. Um, Make sure everyone you check out her socials. They're on our Instagram. And thank you everyone for attending. The link to the Google form has been posted in the comments as well as our Instagram bio. So if you fill that out within the next 30 minutes, we'll be able to receive the verification for your attendance. So thank you so much, everyone.
Thank you. Thanks, everyone. Good talking to you.